Now let us look at how do we do the APC of the edges. There are a couple of techniques that one can use to reduce the recurrence rate after polypectomy. I prefer to use APC. That's where we have the maximum experience. And as you can see, I'm using APC with a forward jet, 35 watts, zero point 0.8 liters flow. And I would like to treat the edges a little more aggressively, especially in anybody who has come in with incomplete resection and scarring. So I'm using forced APC, not pulsed APC, and with each tap I apply the organ plasma coagulation at one spot, and you can see the spots are brown. Unlike the snare tip soft coagulation, which tends to cause uh, just a whitening. The reason I think that this may be more effective, although we don't have any randomized control data, by creating a brown effect, you are likely to cause a little more deeper mucosal injury and hopefully ablate any neoplastic stem cells at the bottom of the crypts. As you know, most of the stem cells start at the bottom of the crypts, and you want to make sure that your energy reaches there. And once I treated the front end, I start at the top end, and then I come down. Uh, for lack of a better way, I come down from the north to the south along one side, millimeter by millimeter, and in between you may want to decompress the colon because organ doesn't get reabsorbed, and follow the path. And you don't want to leave any bridges of tissue that has not been treated by APC. And this takes probably quite a bit of time. And for your sake, I did not edit this video, and you're seeing it from the beginning to the end of my APC application. And wherever I apply hard biopsy avulsion technique, taking out tethered area, I'm more careful in terms of treating that area a little more aggressively. So we treated the top end. Now I come to the left side and again start at the north side and then come down south, millimeter by millimeter. And this is possible if you have your patient under general anesthesia. I don't have to fine tune my application trying to time it with the respiratory movement. When you do procedures under general anesthesia, the colon is relatively stable and you'll have a much, much better outcome in terms of your treatment effect. You have to keep in mind that you are trying to do this resection to avoid a major surgery. Major surgery requires general anesthesia and all the other things that go along with that. So why not apply general anesthesia, get the patient intubated. Sometimes I ask my team to even paralyze the patient and control the tidal volume, especially when I'm doing the procedure in the transverse colon or at the flexures, so that there is very little respiratory movement and my procedure is much more efficient and much more uh, safe and also very effective in terms of delivering the treatment where I need to deliver. You can see that this is a totally unedited video from the beginning to the end of the APC. And you may be thinking, hey, how is this guy able to do this? The trick is Try to plan the procedure with the help of an anesthesiologist and do the procedure under general anesthesia with endotracheal intubation. It's very well, it's worth that effort. So once I do the APC, I take time, make sure that I covered all the areas that I need to cover, and if I needed to treat areas in the center of the resection, uh, I want to treat it so that the whole effort is to reduce the risk of recurrence. So focus on the edges. Make sure you go step by step from one end to the other end, covering all the areas. And also keep in mind how your resection went, and wherever you thought that you had a tough time to resect or your snare was a little bit superficial, those areas you go back and apply the APC. But one thing is I want to share with you, that is to keep in mind your scope position and ask yourself, could you close this defect? And if you could close the defect, if you apply a little more aggressive APC, as long as you're able to close the defect, your chances of getting into any issues will be less. So here is the scar tissue, and here is where we did the resection plus hard biopsy avulsion at that small red spot that we removed at the uh, before cleaning it out. I want to make sure that I treat that and take care of it. As you can see here, there is a little area that we didn't cover in the initial thing. I want to cover that. So these are the principles that I use. So APC, 0.8 liters flow, 35 watts. And this is, I was able to do this because I had a good submucosal injection cushion. And if you think that you didn't inject, you can inject some more into the edge and then apply the APC. And once you've done your treatment, take time to go around and take photos like I'm doing here and document that in your report.